Majid Shafiq. I am the moderator of this APPNA Merit daily webinar today. Thank you very much to everybody, all the panelists, all the attendees for joining in. Let's review the format of this event. What we do, as we do every day, is we have one of our panelists who happens to be a formal speaker who will give us a short talk about one specific aspect related to COVID. As we get towards the end of that, all the attendees are most welcome to use the Q&A feature within Zoom. You'll see that to drop in any questions. Obviously ask questions related to the topic that we're talking about, but feel free to really ask any questions that you want. We have a nice diverse group of panelists today as well, who will introduce themselves after the formal talk is over, and we'll be happy to take any and all questions related to COVID management. So with that, I will turn it over to Dr. Tayyib Rana, who is an ophthalmologist in the DC area, DC, Virginia area. We are very pleased to have him today, and he's going to be talking about ophthalmic manifestations of COVID. Dr. Rana, you can go ahead and you can share your screen as well. Thanks all.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everybody. When I signed on for this presentation about 8 or 9 days ago, I thought there would be a lot more data that we could present in terms of the ophthalmic manifestations of COVID-19. But thankfully, the ophthalmic manifestations, contrary to what we heard in just some very few news reports, is not a very common presenting sign or symptom within the COVID-19 spectra. So having said that, however, ophthalmologists can be the very physicians who come into contact with COVID-19 patients from the onset. So I'll keep this as brief as possible with some pertinent points and some guidance for how to deal with this setting in ophthalmology and patients. A little background, as everybody's been hearing this last week, that COVID-19 caused by the SARS-CoV-2 virus, which is an enveloped single-stranded RNA virus, which causes the disease COVID-19. Its presenting symptoms are well known. These can include anything such as GI symptoms, conjunctivitis, fever, cough, shortness of breath. The transmission is felt to be mostly aerosol transmission, but it can be hand spread as well. The interest in the ophthalmic side of this emerged initially from reports out of China that, as we know, that there was an ophthalmologist who unfortunately passed away from COVID-19, who had started reporting a series of patients who were presenting with fever, respiratory illness, very similar to what he had seen during the SARS outbreak. And he didn't necessarily see conjunctivitis in all these people, but he saw enough of similarity between these patients that he started contacting his colleagues and suggesting that perhaps there was a new novel virus that was causing an outbreak. And of course, the rest is history, what happened there. Now, fast forward to present day, April the 9th here, 2020 in the United States. When the first cases broke out in the US in the state of Washington, there was some reports that came out of a nursing home from a registered nurse, which was reported on CNN, that almost 90% of patients that she came into contact with COVID-19 had presented with red eyes. Now, since that time, there have been a few studies that have been published, retrospective, out of the Chinese, mostly out of Chinese Hubei province, which showed that the majority of patients with COVID-19 did not actually have conjunctivitis. One of the studies that was published in the Journal of Medical Virology looked at 30 patients who were hospitalized for COVID-19 in China. Of those 30, 1 had conjunctivitis, 29 did not. Now, in the patient that had conjunctivitis, they were found to have SARS-CoV-2 in the ocular secretions. There was a larger study that was published later in the New England Journal of Medicine that studied about looked back at about 1,100 patients. Out of those 1,100, 9, which amounts to 0.8%, had conjunctivitis and laboratory confirmed COVID-19. None of these were documented to have seen an ophthalmologist prior to presenting with the disease. Just recently on March 31st in JAMA, there was another study published which looked at about 38 patients, 12 of whom showed ocular surface abnormalities. However, this was characterized mostly as chemosis, which went on to be commented on in the New England Journal of Medicine Journal Watch, which said that at least a third of patients, or concluded that a third of patients presenting with COVID-19 had conjunctivitis. The American Academy of Ophthalmology went back and looked at this commentary and disagreed and said that you cannot call chemosis a conjunctivitis, that this probably represents a third spacing or fluid overload and not infectious disease on the ocular surface. Now, when it comes to the spread of the disease, the theory here is that there is aerosol coming into contact with the conjunctiva, or there is hand-to-eye contact, which is causing the conjunctivitis. So far, at least to my knowledge in my research and what we've seen clinically ourselves, there has been no conjunctival sampling that has shown active virus. However, there have been case studies where, as I just mentioned, one, that there was virus in the conjunctival secretions. Tear film presence of SARS-CoV-2 is still a questionable subject, whether that's actually happening or not. So what are we then seeing in those few cases of ophthalmic manifestation of COVID-19? 2 is then a follicular conjunctivitis, very similar to most of the other viral conjunctivitis that we see, especially adenovirus in the clinical setting. So as an ophthalmologist, if you have a patient that fits risk factors and has conjunctivitis, then your clinical suspicion should be very, very high. There are, as we know, asymptomatic carriers who are transmitting virus. In those cases, I just had a patient actually this morning who presented with mild, what appeared to be a sinusitis and a clear conjunctivitis. And I did send her to the hospital for further investigation as a possibility of COVID-19 infection. So as a clinician ophthalmologist, what are questions you should ask yourself to identify patients with possible exposure? Well, these have been discussed here in this excellent format this last week. Does your patient have fever or respiratory symptoms? Has your patient or their family members traveled recently to hotspots? Has your patient been in the presence of someone with COVID-19 in the last 2 to 14 days? And then based on these questions, there are protocols that are established and recommended here in the US by the CDC and by the American Academy of Ophthalmology. And that's really, I'd like to highlight on, because that can be helpful to clinicians or practitioners that may be listening in on this particular talk. So the updated recommendations from the American Academy of Ophthalmology are that if your office setup permits it, then when patients come, screen them before they actually walk into the waiting room. You should ask them those pertinent questions that we just discussed. And if they fit that profile, send them right back to home to either call their primary care physician or refer them to an appropriate facility where they can be tested and ruled out for COVID infection, and keeping in mind that these patients can be asymptomatic for an average of 11 days post-infection. Keep your waiting room as empty as possible, and you want to advise any patients that are in the waiting room to sit 6 feet from each other, just as in any other clinical setting, for appropriate social distancing, and reduce the visits, of course, of vulnerable patients. Within the examination room, when you're talking about commercially available slit lamps, most of these have breath shields which are available, and the use of those breath shields is highly encouraged. In fact, most of the manufacturers are now giving free breath shields to use in the clinics, as any ophthalmology practice may apply for those. They add a measure of protection against the virus. However, keep in mind that breath shields are not barriers to contamination on the side of the patient. The patient may have touched, coughed on those barriers, and that can lead to transmission on the staff or next patient that comes through. Ophthalmologists should also basically inform their patients before they actually start the exam that they will speak very little during the examination, and request that their patients also refrain from talking. When it comes to in-office procedures, obviously at this time, elective procedures really are being avoided. But if it's necessary to perform a procedure, it's then recommended that the staff and the patient be masked, and that the operating clinician should be masked appropriately. Now, whether they should be wearing an N95 mask or not really depends on the clinical circumstances of the patient. I'll get into just a slight more detail in just a minute. And of course, we all know that CMS and the HHS over here in the United States has expanded the use of telehealth services during this COVID-19 crisis. Okay, so very quickly, what are some of the guidance for triaging ophthalmic patients as they present? Well, for routine ophthalmic issues, and even for previously scheduled appointments, both the American Academy of Ophthalmology, the American College of Surgeons, and the CDC has made it very clear that routine problems should be deferred and previously scheduled appointments should be canceled. Appointments should be rescheduled, and only rescheduled actually upon clearance from the public health authorities. Medications can be refilled over the phone or electronic systems. The second scenario is an urgent ophthalmology appointment for a patient that has no respiratory illness or no fever and no COVID risk factors. So what do you do with these people? You use standard precautions. There's the added precaution of not speaking during the slit lamp. And in the setting of adequate PPE, the use of a surgical mask and eye protection for the clinician is recommended. The third group are urgent ophthalmic patients with respiratory illness, but they don't have fever or any other COVID-19 risk factors. These patients can be seen in the eye clinic. However, extra precautions should be used. The patient should be placed in an examination lane with a door closed. Surgical mask should be placed on that patient. The staff should be masked. The treating ophthalmologist or any other assisting clinician should require surgical masks at minimum, if not an N95 mask in appropriate clinical setting. The examination room absolutely must be disinfected after the examination. The last two groups, the first of which is the urgent ophthalmic problem in a patient who is definitely at high risk for COVID-19, but not proven infection. This patient is best sent to the emergency room or other hospital-based facility which is equipped to evaluate and manage COVID-19. Now, when we say another hospital-based facility, this should be a facility that not only knows how to manage COVID-19 infections, but also knows how to manage urgent eye problems. That's very important. And the last group is the urgent ophthalmic problem in a patient with documented COVID-19. This patient is usually going to be consulted from the hospital itself. But if they're not, again, they should be immediately triaged to a facility that is absolutely expert in the treatment of COVID-19, and all known precautions should be taken. And in that case, even the treating ophthalmologist should be wearing an N95 mask, gown, gloves, and eye protection. One topic that I do want to touch upon, because it's still being talked about a lot across the world, is some of the novel potential treatments. Interestingly, one of which is use of chloroquine, hydroxychloroquine. The American Academy of Ophthalmology doesn't have an opinion on this, but they do say that because there is no strong evidence for the use, we certainly are not recommending it. But one interesting aspect of this is that there was a study done by the Asia Pacific Vitreoretinal Society that found that the proposed doses of the treatment and use of hydroxychloroquine and chloroquine in these patients far exceeded the safe dosages to use from an ophthalmic standpoint. and the risk of irreversible maculopathy at these higher doses for a short period of time really is not known. And that if this is going to be administered, this drug, especially in the less serious setting, it definitely needs to be discussed. This is an aspect that should be discussed with the patient. The use of testing like ERG, for example, is really not a well-studied test. It's not a well-studied testing situation. Therefore, there's really no recommendation on this, and as well as OCT, which is usually impractical in settings of patients who are that sick. The last thing I want to touch upon is the guidance for outpatient and elective surgery. It is an absolutely clear advice from the American Academy of Ophthalmology, the American College of Surgeons, and from the CDC that all ophthalmic elective surgeries and visits should be indefinitely postponed until there is clearance from the health authorities. Oh yes, one thing I forgot to touch upon was the cleansing and disinfection of slit lamps and ophthalmic devices. It's fortunately in ophthalmology, we generally do, we're generally very obsessive about how we clean our equipment and our lanes. You can use diluted household bleach, about 5 tablespoons of bleach per gallon of water, and that's plenty to disinfect the equipment and the slit lamps. Alcohol solutions with at least 70% alcohol. Remember that the virus causing COVID-19 is an enveloped virus. Unlike adenovirus, which is much more resistant to alcohol, the the SARS-CoV-2 is readily dealt with by using these solutions. So the take home from this is that the reports and the clinical experience and retrospective studies suggest that COVID-19 can present with mild follicular conjunctivitis that is otherwise indistinguishable from other viral causes and most likely transmitted by aerosol contact with the conjunctiva. Patients who present to ophthalmologists for conjunctivitis who also have fever and respiratory symptoms, including cough and shortness of breath, and especially those who have traveled to hotspots, whether in the United States or abroad, or have family who have been proven COVID-19, these patients really should be seen in the setting of experienced COVID-19 treatment. And the Academy recommends absolute protection for the mouth, nose, and eyes if possible, where there's not a shortage of PPE, even in mild cases. Thank you very much.
Well, great. Thank you very much, Dr. Tayyib, for a very nice, comprehensive overview of the ophthalmic manifestations of COVID. We have a nice long list of questions, both related to ophthalmic and non-ophthalmic aspects of COVID. We have several in the Q&A section today, and then we have several online as well. So I would estimate that if I will sort of direct every question to one panelist at a time, and if we can try to keep the answers brief, 30 to 60 seconds if possible. Let me first direct some ophthalmologic questions towards Dr. Tayyib. One of the questions being, if a physician is wearing eyeglasses, do you think those eyeglasses will offer any protection if face shields are not available?
Definitely, that having any layer of protection in front of the eyes is better than nothing. But in my practice, I still would advocate the use of eye shields if there's not shortage of PPE to be used elsewhere.
That's great, thank you. Now, another question is, are there any antiviral drops or eye ointment that is approved for patients infected with COVID?
So again, controversial, not studied, not known. In a suspected case that I had this morning, I did start her on antiviral. I did start her on Zergan here in the United States, but this is not proven. There's no proof that this is effective.
Okay, great, thank you. Another question for you, Dr. Tayyib, is there a way to test or establish that the virus is secreted in lacrimal fluid? And if so, Could that, you think, be used as sort of a test in some way?
So we have not had a case where I have personally tested that, but as I mentioned that there are several retrospective studies that did go back and look at that, and secretions were tested, and of those secretions, about half were found to have SARS-CoV-2 present. But then there were those proven COVID patients with conjunctivitis that did not show SARS-CoV-2 in the secretions.
Okay, wonderful. I think almost a related question here is, one of our attendees sort of wondering whether when we talk about conjunctivitis being a manifestation of COVID, do you feel like that could contribute towards, infectivity of the patient?
Well, again, a bit theoretical, but if the presenting sign of COVID-19 is conjunctivitis, and if the secretions in that particular patient have viral load, and then you have hand-to-hand or hand-to other person, or let's say fomite transmission, then yes, then it could absolutely spread the disease that way, no doubt.
Okay, excellent. Thank you very much. I'm going to shift towards Dr. Mehreen Arshad, who is an esteemed pediatrician as well as an infectious disease expert and a physician scientist in Chicago, USA. Dr. Mehreen, one of the questions posed by the attendees was, what are the usual clinical manifestations of COVID among children?
Assalamu alaikum. So thank you for asking that question. It's interesting because children, as you know, are not don't seem to be as affected from COVID-19 as adults. That doesn't mean that they are not getting infected. They are, but they just don't seem to have as severe disease. Their main, so up to 30% of infants or children in general can be completely asymptomatic. So, we've tested children because their parents were positive, and but the children themselves have had no symptoms, and they still test positive. The more common symptoms seem to be cough. There's some kids will present with fever, and some can present with diarrhea, abdominal pain. Some of them can also have nasal congestion. It is very hard to distinguish that, COVID-19's related symptoms from just a regular viral infection, especially in children. The one thing I will add is that more than 90% of children who are positive have a family history of, have other family contacts who are also positive. So when we've been looking at children in our practice and deciding whether or not we should test them for COVID-19, we've looked at fever, cough, presence of fever, cough, and it can be, in adults they say dry cough is more suggestive of COVID-19, but in children we found that really any cough, even if it's sort of some stuff with nasal congestion is possible, and especially if there is a family history of positive contacts with COVID-19. So those are the kids that we've been testing. And I will say even within those children who have who have a strong family history, even among those, we've only found about 15 to 20% of them are positive.
Okay, great. Thank you. Another question that one of our attendees online has directed towards infectious disease. So Dr. Mehreen, I'll pose this to you. I think it's an interesting, intriguing question. They're wondering if the total duration of infectivity of a patient depends on the severity of illness that they do have. And so whether or not we should tailor our recommendation for how long a patient should practice extreme caution with social distancing.
Yeah, that's a very interesting question, and I don't think that we have good data to answer that question, because we certainly have had people we've seen people who have had mild symptoms but remain positive on PCR testing for several weeks. We've had patients who have been admitted in the ICU and have come out of the ICU and recovered, who have become negative after after a couple of after their major illness is over. So I don't think that we know that there is a strong correlation between the infectivity and the severity of disease. What we also know is that the viral load, so the number of viral copies, is also not associated with the severity of disease.
Okay, excellent. Thank you. I'm going to ask a question of Dr. Fawad, one of our pulmonologists and intensivists today. And I see he has a hand raised as well. So Dr. Fawad, you can certainly chime in about this particular or any other points you wanted to make too. But in addition, one of our attendees, Dr. Imjad Hussain, is asking, he's come across the use of ultrasound to spot early manifestations of pulmonary diseases. And so do you feel like a resource-constrained country such as Pakistan should really invest in portable ultrasound probes? It's a loaded question. I know what my answer would be. It'll be a resounding yes, but I'd love to hear what you have to say about that.
Right. So first, I think I just wanted to comment regarding the pediatrics and COVID-19. And again, I'm by no means any expert there because my practice is mostly adults. So, but there is a recent paper published regarding the frequency of infection in kids and their morbidity and mortality. And I think till April 2nd, the data showed 1.3% kids affected, and there were total of 3 died. So overall, the rate of infection is much less, and from that paper, and the mortality is low. But again, just the attendees and panelists who want more information can review the paper, because again, as I said, I think the pediatricians will be better to discuss those results, but it seems like it's much less common. That's that. I think the second aspect, the question, Majid, was
ultrasound.
Should they invest in ultrasound in Pakistan, which is resource limited, for critical care in general, or we're talking about COVID-19 specific at this time, or either or?
Currently, the attendee posed the question in the context of COVID, given the incoming data that you could use ultrasound, including point of care ultrasound that Dr. Moten also sort of pointed towards.
Yeah, I think, again, my answer is, of course, I think that is the single most important thing that we can do at this point as intensivist. We do use POCUS quite a bit, which is a point of care ultrasound, as Majid mentioned. And especially, they are not very expensive, but you can do all the bedside things from diagnostics all the way to therapeutics with just one ultrasound, with 2 different probes. For example, these COVID patients, we are not even doing CT scans as often. We are relying on chest X-ray from the ER and then ultrasonographic manifestations of, ARDS, B lines, pulmonary edema. Plus, if there is a pneumothorax, we detect from there. Plus, you can do abdominal ultrasound at the same time. Plus, you can put lines in, taps, chest tubes, whatever you need with that ultrasound you can do. So I think that's a very worthwhile investment. And there are some very small handheld ultrasounds which are much cheaper than the big. Those are also worth looking into. There are some ultrasound devices that you can connect with the iPhone. So I mean, there is a host of different things that can be done, but it is definitely worth giving it a worth considering it on the higher list in terms of budgeting. Anybody else has a comment, please welcome, but that's what my thought process there is.
Thank you. And Dr. Sajid, you wanted to chime in as well. I see the raised hand, one of our other panelists. Please go ahead and introduce your specialty and let us know what you have to add.
Yes, this is Sajid Mehmood. I practice critical care in Chicago. Regarding ultrasound, in COVID-19 setting, whatever literature I have I have reviewed, those are saying that those are no different than CT findings, and typically creates COVID-19 patchy abnormalities on CT scan, and ideally those can be missed unless you do ultrasound overlying the abnormal lung tissue. But logistically, as we all might have examined, that once they are in negative pressure room and so much isolation and restriction, I have not seen any of my patient on mechanical ventilation and who is COVID positive leaving that room for CT scan. So I guess under those circumstances, ultrasound of lung can be a very useful resource so that you can pick up the same findings using an ultrasound probe and preventing patient to leave the room, go to CT suite.
Thank you very
Yeah,
much
and
for that. Go ahead.
I just want to add the same thing. Even the protocol at the University of Oklahoma, where we have in the protocol chest X-ray and or ultrasound. We do not have a CT scan unless absolutely necessary.
Exactly.
This is great. And one quick thing that I would add to all our attendees from Pakistan, though, is whenever you're trying to bring in a new modality, just bear in mind that there's always a bit of a learning curve. Here in the US, where ultrasound, and especially point of care ultrasound, which refers to the clinician using a handheld or a portable ultrasound, bringing it to the patient's bedside and using it for either procedural guidance or to make clinical decisions and assessments, even that has had a slow rollout. It's not that easy, and it's certainly time consuming to train senior clinicians who are well versed with what they're already doing and very good at what they're already doing in a completely new and a completely different modality. I think the question overall, though, was great for a resource-limited country in particular, but really for everybody in general. Ultrasound, especially when brought to the bedside, has a lot of advantages. I think what better time than now to start thinking about it, budgeting for it, investing in it, finding the right online resources, and perhaps also the right kind of educators from other more experienced centers who could perhaps come in and help with hands-on teaching. This requires workshops, this requires a lot of practice, feedback and such before you get really good at this kind of stuff. Unfortunately, and fortunately too, inshallah, this pandemic will be over by the time, someone will be able to sort of become an ultrasound expert to use ultrasound independently if they haven't done that before. I'll move to the next question, which is also sort of relevant to the pulmonary field. So Dr. Sajid, Dr. Fawad, and others can also chime in. The question is, as we know that the radiologic manifestations of pulmonary sort of COVID sometimes herald clinical symptomatology, do you think or recommend that we could use chest X-ray as a screening tool for COVID patients, especially in a place like Pakistan before symptoms become clinically manifest? Dr. Fawad, would you like to start?
Yeah, I think I think it's a great question, and I'm not sure if there is any real 100% good answer to that. The problem is, and all of us have seen it, that they can present with a almost normal looking chest X-ray, and 12 hours later they are in respiratory distress because many of those ground glass opacities do not appear as well in chest X-ray. Having said that, most of the patients that I've seen going into failure rather quickly, I have seen interstitial pneumonia pattern. So I think it's in Pakistan with resource limitation, it is reasonable when you're suspecting. I'm not sure applying it blandly for screening will be cost effective there. But yes, if you are suspecting a COVID infection, definitely go for chest X-ray in the emergency room. You might get some answer. And if there is manifestation on the chest X-ray, then I would definitely worry. So most of them don't show it, but if there is something on the X-ray, those are the likeliest patients who may go into respiratory failure. I will end
Dr.
my.
Sajid, would you differ or add anything to that?
Well, I would strongly favor chest X-ray, even if you have to do at an early stage. The rationale for that is that even though the triad of COVID-19, shortness of breath, cough, fever, those are there, but as we all know, those are very non-specific and can occur in multiple other conditions. Plus, the other thing which is also very strongly associated with COVID-19 is silent hypoxemia. The patient will not demonstrate any significant distress. They will able to talk, they will be sitting comfortably, but the degree of hypoxemia can be severe. So in that case, chest X-ray might be helpful in diagnosing cases earlier, and especially with the cost and the ease, I guess the stake is high and the benefit is more. So I would strongly recommend that.
Okay, now I'm going to ask a question of Dr. Tayyib, an ophthalmologic question, but before that I'll give a heads up to our panelists. I'll also be asking about dermatologic manifestations of COVID-19 next. If any of you is prepared to answer that or want to review anything before I get to you. Dr. Tayyib, if you could please talk about, are there any long-term or chronic sequelae of COVID survivors in terms of visual symptoms or any other ophthalmic manifestations that you're aware of?
Thank you. Yeah, we just, again, don't have enough time study to know whether the ophthalmic manifestations move beyond just conjunctivitis. In other words, do we get an inflammatory response of uveitis, anterior, posterior, panuveitis? Do we get any kind of retinitis, choroiditis? There just is no clinical data out there to know, because these patients are so sick, they're in the hospital. We as ophthalmologists have had very little chance to get that in depth with these patients. So we just don't know at this point.
Great, thank you. And who could speak about dermatologic manifestations of COVID-19? Any of the panelists?
Sorry, not me. I haven't seen much, so I would pass that on.
Okay.
Neither do I. I don't think so. I've seen anything specific, or I've heard anything from my colleagues.
Okay.
So
thank you. Well, there are some reports that you could have erythematous patches that I have heard about. I see Dr. Mehreen is unmuted as well. Dr. Mehreen, do you have anything to add?
Yeah, and I was just going to add, it looks like some people might have urticaria associated with which has been chalked up to COVID-19, but it really does not seem to be a significant part of the symptomatology of COVID-19.
Okay, excellent, thank you. Now, Dr. Mehreen, will stay with you. There are a few questions, pertaining to, of course, antivirals. As you know, there's a lot of interest. There's, also, of course, a lot of hope, for that. People have asked about, any specific antivirals that you would say at this time, as of, April 10th, 2020, that are really sanctioned for use. One of our attendees has specifically asked about ivermectin as well. I'm sure you've read the paper on in vitro activity. If you could give us a nice snapshot. Of course, this is a whole talk in itself, but and we have been talking about this every day, but as of today, Dr. Mehreen, in your practice, if you were to see an adult patient who was severely ill with COVID, what would be your sort of number one, number two agent?
Yeah, so we unfortunately, I don't think that we have any good data to support use of widespread use of antivirals. I think we've talked about hydroxychloroquine and azithromycin, which the data, that paper has almost been retracted, and so there really isn't a lot of data to support the use of that. In ivermectin, as you mentioned, it was only there's only in vitro data for that, and if you look at the paper itself, the level of ivermectin that was used is about 200 times what our normal, so if you treat a patient with a usual dose of ivermectin, that is 200 times less than the dose that was used in vitro assay. So again, not something that I think can easily be translated to clinical practice. Unfortunately, I think the drug that probably has most the antiviral that has probably most promise right now is remdesivir, which is only available in the US, and I know it's some other parts of the world, probably not in Pakistan at the moment. And that too now, even in the US, that is not available. It is only now available as part of drug trials. And so you cannot get it as part of, compassionate use or other reasons. We have had some, and so, even though I'm a pediatric infectious diseases, because we're trying to help our adult colleagues out, we have started to see some adult patients as well. And so we have, we've used remdesivir. We have also used tocilizumab, which is an interleukin-6 inhibitor with some success. And again, the idea behind the use of that is that a lot of the mortality, morbidity and mortality and the severity of disease is related to the immune system, overactive immune system, rather than the virus itself. And so I think immune modulators will probably, I think, have a significant role. The other thing I know that there is some talk about using plasma in Pakistan, as well as, and there are some trials going on over here. I think that too is promising, has shown some promising results, but only in very small case series at the moment. And there are lots of problems with using and availability of plasma. So I think really nothing seems to be the go-to treatment at the moment.
I would echo that as well. At this time, really good supportive care. Remember, the vast majority of patients who will get infected will recover, and that'll really be a function of their own bodies and their own immune systems. Our job is mostly, first and foremost, to practice good medical care, and if they get sick enough to require critical care, then practice good standard critical care, and of course incorporate adjustments as required by the patient's individual physiology and as more and more data becomes available. Dr. Mehreen, I want to actually ask you to take on this series of different questions that really talk a little bit about worldwide epidemiology. And I will start with you, but really any and all panelists are welcome to join in. And I'm specifically starting with you, Dr. Mehreen, because I have heard you or read some of the the comments, the very insightful comments you've made. There continues to be a perception, at least you can correct us if it's a false perception, that COVID-19 is really bad in America. Maybe it's not so bad in Pakistan, and maybe it's a function of who we are, what we got at birth, or what other diseases we have, and so on. Should we feel optimistic about that? Does that give you a lot of optimism? What's your take on the worldwide epidemiology of COVID-19?
Yeah, that's a good question. So I think the one question that always comes up is, are there different circulating, serotypes of the virus? And I don't think that we have any data to suggest that there is more than one kind of SARS-CoV-2 virus that is circulating in the world. I think part of the reason why this is maybe more common is in the West is I think, as you alluded to, is that is testing capacity. And I know, in the US, we've certainly had delay in testing, and we can say I practice in Chicago, and even now in parts of Illinois, there really isn't a lot of testing going on. But as soon as testing is introduced, the number of cases in that particular region, specifically rural areas in Illinois, seems to spike, and so do the corresponding number of deaths. So I think there certainly is a role of limited ability and capacity to test in different parts of the world, which may explain the difference in the kind of in the numbers that we're seeing. I also think that in parts of the world, like I know, for example, in the US, there is different states have undergone lockdown or quarantine or stay-at-home orders at different rates, and those states that seem to have jumped on this earlier on have seen lower number of cases. Those states that sort of did not jump on this earlier have had more cases. I think the other thing that I think is also important, and so I know you sort of alluded to the BCG vaccine, which has gotten a lot of press lately. I don't think that that's the story at all, because there are a number of reasons that places, so for example, places that routinely give BCG vaccine also tend to have limited resources, and which would typically translate into less testing as well. So that may be one of the reasons why we're just not seeing a number of cases. The other issue is that some of these countries may not have more international travel, which is why they may have less cases. They also tend to have younger populations. Because remember, one of the reasons that we think Italy had such a huge problem is because they had the oldest population in the world, and we know that most of the severe cases tend to happen in the elderly population. So I think putting all of that together, I think, and I think there is some recent data coming out in terms of the ACE receptors as well in the lung and the genetic differences in different populations. And so perhaps there's a host component to that as well. And to answer your question about should we be cautiously optimistic in Pakistan, I think we're a little early. I don't think that we should be, because I think there is still a lot of there is a possibility that we'll have more cases as testing increases, and as people. I know there's a lot of places that are in lockdown right now, but as businesses open, this will spread. It's also important to remember that if you look at the natural curve of this, when this number started to increase, it's usually about 2 to 3 weeks after the first detected cases. So if you look at the timeline of these positive cases in Pakistan, it basically started about 2.5 weeks ago or so. So right about now, or in a week from now, is when you would start seeing the exponential increase in cases and the deaths, because deaths from COVID-19 typically happen in about the 2nd to 3rd week after getting infected. So for all those reasons, I think it's I think there's a lot of interest in looking at the discrepancy in different parts of the world, but I don't think there is any region in this world that should be optimistic to the extent of not doing anything about the disease and not practicing social distancing.
Yeah, this is Avais Masud. I totally agree that we should not be in Pakistan in any illusion that we have some kind of protection or immunity, but only one thing I've seen here, especially in New York and New Jersey, a vast majority of the patients who have done badly, they were obese. So I think it has a factor. I think obesity is more in Western countries and particularly in USA. I have one family which was reported in the newspaper also. They actually, 6 of the same family, and they all passed away. They were intubated, and one thing common was all of them were more than 250 pound weight. So maybe that's one reason that obesity is not that much in Eastern countries. But I agree that BCG or any other thing, we should not take for granted that that will give us any protection as yet.
Thank you very much, Dr. Avais. Dr. Fivzia is one of our panelists from Indus Hospital in Karachi. I'll begin by asking her, but really anybody else is welcome to chime in as well. One of the questions asked online is if anyone knows the cost of a ventilator in Pakistan. Dr. Fivzia, are you aware?
Yeah, it varies from hospital to hospital. At Indus Hospital, it's a
Dr. Fivzia, you are muted. You'd have to unmute yourself.
Oh, oops. Assalamu alaikum. Sorry. Yeah, so it varies between hospitals and hospitals. Indus Hospital is a completely charitable hospital. We don't charge anything to the patients. However, it varies from anything around 30,000 going up to 60,000-70,000 per day just for the ventilated costs.
Excellent. Thank you very much. Now, this question comes up frequently, and it's a very important question. Healthcare workforce is under grave threat, and it's a precious commodity, even in the best, the most resourceful of healthcare centers and institutions across the world. I'm going to ask Dr. Mehreen first, and then I'll really want whomever wants to chime in further, please go ahead. If you could share your thoughts about why it seems like from some reports out of the US, healthcare providers seem to be getting very sick, even if they don't otherwise have a lot of those usual risk factors such as advanced age or comorbidities, etc. And do you think it's a function of higher viral loads? And tied to that is another question about prophylaxis for high-risk groups, and if so, what kind of a dose would you be using if you were going to use hydroxychloroquine, for example?
Yeah, so that is interesting. It's so if you look at general population, again, it's the viral load does not seem to correlate directly with the severity of disease. It may, so it's hard to know, and I don't know offhand. I know that it seems that a lot of patients who, healthcare personnel, are getting very sick, but I am not aware, I don't know, Majid, if you know, but if there is, I don't know if there's a study that has looked at healthcare workers alone. I know that a lot more, like if you look at the general population versus the healthcare workers, a lot more healthcare workers seem to be getting infected for sure. And that's probably related to, greater exposure, greater, just higher risk because, and higher, the patients that you're seeing in clinic and in the hospitals tend to be more severely sick, and so they may have a higher viral load as well. I don't think we know for sure if it is viral load driven as such. Again, it is a possibility, I suppose. I mean, in terms of the prophylaxis for healthcare workers, again, there isn't any guidance per se on this, and like I said, I think the data for hydroxychloroquine, as we've as time passes, seems to be less and less suggestive that it's actually doing anything. There are some, I know there are at least a couple, at least one large study that is ongoing right now using hydroxychloroquine in healthcare workers, and we're hoping to get some results from that in early May. So we might get some idea, but at the moment, I don't think that we have enough data to support use of hydroxychloroquine in any population at this time.
Thank you. I'm going to go to a couple of other panelists too who have their hands raised, and I'll quickly add, as far as the doses that are being looked at, in that large, multi-center study going on in the U.S. right now for high-risk healthcare workers, defined as those who are either doing a lot of aerosol-generating procedures, such as pulmonologists and such, or ICU physicians or physicians in the emergency department, ENT surgeons, that kind of thing. What they're looking at is either a once a week or a twice a week dose of hydroxychloroquine. Dr. Fivzia Harikar, you have something to add to that?
Yeah, I was just going to add the same thing, that it's related to the procedures that have been going, and hence it's extrapolated that it's because of the higher viral load. However, one of my points in Pakistan and what we are facing is that being an Islamic country, we have a lot of healthcare physicians who are wearing, healthcare workers who have a beard, different sizes of beard. Now that's creating a huge problem for us because we have, number one, not as great of big force that we need for dealing with COVID patients. Then we don't have expertise as much as possible to deal with this. ICU patients are stopped. We've been pulling out them from general wards and teaching them how to do it. And then we have the PPEs, which N95 is not recommended in people who have beards. So that is one issue, and it would be interesting and actually scary to look into the numbers of healthcare workers who have a beard who get exposed to COVID.
It's an excellent point, and I'm going to go to Dr. Fawad as well in case he has more to add. I see his hand raised. Thanks, Dr. Fawad. And I'll quickly, add here in the US, if you have a beard, you automatically get disqualified for the N95 mask. And so if you are going to be participating in an aerosol generating procedure, you need a PAPR. So go ahead, Dr. Fawad.
Thanks, Majid. So I just posted a link on COVID on our website. I think it went to the event management, but I'll do it on this side as well. So regarding, do we have any evidence of viral load and sickness of the physicians? We don't. I agree with the other panelists. However, there is a paper, there was a small paper by Stanford, I think came out a couple of weeks or 3 weeks ago. The initial deaths that happened in Wuhan were in ENT surgeons as well as in Iran. And there was a specific procedure list in that paper where there were 10 ENT surgeons / neurosurgeons did a case. All of them got exposed and all of them were hospitalized and many of them are on the ventilator. And from that, it was extrapolated the more direct nasopharyngeal and airway procedures and longer you will do those procedures, there is a likelihood that you will get high viral exposure, and the higher the viral load, there might be a chance that you get sick. Now, whether that higher viral load will get you more sicker than others, we don't know, as other panelists suggested. So the second point to that is from our IP society as well as all the other subspecialties. All the elective procedures are that's why kind of banned, or we are not doing it unless urgent or emergent. And those that we are doing, it's basically double COVID negative, 24 hours apart, and with N95 still. If we do not have a final, if we do not have a double negative or it's a PUI, it's under PAPR. And then finally, regarding mask, as Majid said, if you have a beard or even any facial hair, it's PAPR. You have to be clean shave for the N95. So these were the points I just wanted to make regarding the exposure as well as the chances of infectivity. And I'll just post the link.
Okay, I appreciate that. Now, we are getting close to the end, and I know a few of the other panelists would like to chime in further as well. I will give them a chance, so please hold on to your thoughts for now. What I want to do first is take one more question. I think we've done phenomenally today. We've answered about 24 questions already between the Q&A section here, a couple of questions in the chat forum, and then our online list of questions as well. One more before I'm going to go to some raised hands, at least one or two of them among the attendees as well. One question that I want to touch upon a little bit is sort of the discrepancies that we've seen in terms of testing. One of the questioners asked about, why it seems like sometimes you will get negative nasopharyngeal PCR testing and yet positive lower respiratory tract testing. Is there something in between those kinds of patients that sort of speaks to different predictive or prognostic factors and such as well? Maybe I'll start with Dr. Sajid, if you could take that question and then also add anything else that you have to say. Go right ahead, please. Dr. Sajid Mehmood, you'll have to unmute yourself.
Yeah, Majid, would you please repeat your question, because I could not hear the second part.
Yeah. So, why is there such a discrepancy where it seems like sometimes the nasopharyngeal PCRs are negative, whereas the lower respiratory tract PCRs are positive, and then sometimes it's that the PCR is negative, the CT scan is looking pretty bad. Do different sort of combinations of these helpful diagnostic tests mean something from a predictive or a prognostic standpoint?
Right. Okay, so I will tell you from my experience that, since the beginning of this pandemic, I did get a chance to interact with close to 100 patients in past 3 to 4 weeks. Out of all those patients, only 2 patients did unusual that we were thinking that their clinical suspicion on the basis of clinical suspicion, this seems like COVID positive. They were acting like COVID, but their tests come negative. So we sent that again. But other one, our ER staff did a phenomenal job that they sent the reliable specimen that came positive. But reviewing the literature, it is mentioned that if you perform testing too early in the disease, it will come negative. So I would attribute to these 2 factors, that the timing and the technique. Probably that's accounting for this discrepancy more. And I have to comment on the other thing that you were discussing earlier, if you allow me, just
Go right ahead.
yeah. So about that, personal protective equipment, that it is very important, and I know that Mehreen and Fawad also touched on that. So of course that N95, not only the people with beard, but also with some anatomic changes, they have to be formally go through a testing where they can find out that I remember that in my ICU there is a nurse from Philippines, due to her anatomical features, she was deemed unfit for N95, so she had been
Great.
wearing pepper just like me. By the way, I also have a beard, so that's why I'm not fit for N95.
Great,
And
thanks so much.
saying that just having these devices on disposal is not enough, because I work in 2 hospitals. One of the one hospital has a dedicated person sitting throughout the day who watches people and guide them that, hey, you haven't done thing appropriately. You have to, the donning and doffing it's a separate area, and I know that Dr. Shahid, Rafiq and Danish were planning to have a dedicated session for that. So how to wear it and how to use it, how to
Yes.
keep the order of these things is very important.
Great, thanks so much. Yes, we will definitely be covering PPE in detail, inshallah, soon. And if any of the panelists or any of the attendees would like to sort of become a speaker for that, certainly reach out to us. Now, we do have a few raised hands among both the panelists and the attendees, and I do want to give as many of them a chance as possible. I do want to take one last question from within the Q&A section. Thanks everybody for hanging out with us still. And I'll start with Dr. Mehreen, but others are welcome to chime in if they have anything specific that's different or additional to add. But one question asked here is what's the chance? So I'm just going to quote. What are the chances of hand infection while traveling on bikes without wearing any gloves? But I'll use this to ask Dr. Mehreen, being an infectious disease expert, to sort of just once again review for us real quick, what are the most important things that we need to do to protect ourselves, whether as physicians, nurses, or just as members of the community?
Yeah, I don't think I can give you a number about how, what the risk is of infection if you're just sort of out there. I will tell you that I think the current thought is, and again, I know that, there's some papers out there about aerosolization and airborne properties of this virus, but I think the current thought still is that by and large, this virus is spread by droplet and contact. So meaning that, your hands are extremely, extremely important. And I think, like others touched on, even if you're wearing PPE, if you're not taking it off appropriately, then you are getting yourself infected. And so I think anytime that there is, that you're in contact with any fomites, anything, basically, the chances of your hands getting infected, and then that, and then you're basically self-inoculating yourself by touching your hand, by touching your face, is fairly high. So I think those, there, and then there is some thought that it might be spread by or fecal oral route as well. And so, but again, the way that it spreads by fecal oral route is through hand contact. And so I think contact precautions and droplet precautions are extremely important. And then, N95s during procedures that tend to aerosolize the virus.
Great, thank you. Now, let me go on to ask, one of our attendees who I don't believe that I have answered any of his questions. I think some of the others have had a chance to have had some of their questions answered, but I'm going to ask Dr. Muhammad Nazim Zishan to go right ahead and please make sure you're unmuted and then ask your question live, please. You're currently muted, Dr. Muhammad Nazim Zishan. If you're still there, please go right ahead and unmute yourself and ask your question. And in the meantime, I'll have Dr. Avais Masud go right ahead and make your point, please.
Yeah, I have this question from Farham Kadir, that whether hemodialysis decrease the concentration of cytokines or leukotrienes. So I'm a nephrologist, and I do a lot of dialysis in ICU patient, particularly CVVH, which is a continuous dialysis for 24 hours. But we are doing more now, 6 hours to 8 hours. I think there is no study done on COVID patient, but there have been many studies done on patient with generalized septicemia and infection. There are some evidence that the CVVH or continuous dialysis, it does remove pro-inflammatory leukotrienes and other substances. So there's no evidence on COVID, but my feeling is that's my opinion, that it does help in reducing cytokines when patient is on dialysis, actually, particularly CVVH, which is a continuously dialysis we do for 8 to 24 hours.
Great, thank you very much. Dr. Fawad, I see your raised hand as well. Please go right ahead and make your point real quick, and then I'm gonna let Dr. Shahid make a point as well. Go ahead.
Okay, thank you, Majid. So yeah, I'm gonna quickly touch base regarding the previous question of which sample will have higher yield. There was a study published in JAMA from Wuhan again of 174 patients that they did collect specimens from the sputum, BAL, as well as from the nasopharynx. And the highest amount, it was a 94 to 95% yield or positive results from BAL. I think around 70%, 70 to 74%-ish from the sputum, and approximately 35% from the nasopharyngeal swab. So that clearly depicts in that specific study, which was a decent 174 plus patient study, that the lower respiratory tract has much higher viral load in patients who are sick with COVID respiratory illness. So that's just a reference that you guys can evaluate. And of course, I think about the hand hygiene, that's the most important thing, but I wanted to make a comment. Our third hand, which is the cell phone, is as important as our hands to keep it clean. Some people are just using the little bags, like the plastic bags, to keep, put the iPhones in there and use it. So just keep in mind that you have to clean that, because that is as important as our hands these days. Thank you.
Wonderful. Thank you very much. Well, we have come to the end of a wonderful course, a wonderful webinar today. I think we covered a lot of ground. I do want to let Dr. Shahid Rafiq make a closing statement. Go right ahead, Dr. Shahid, please.
Assalamu alaikum. Can you hear me?
Yes.
Majid, thank you for moderating this, I think one of the best sessions that we had so far. Also because of the wonderful presentation by Tayyib Tahir, and then a wonderful panelist and a lot of questions that were answered. The only thing that I wanted to speak directly to the Pakistani attendees and panelists is that if you please know, if you know that there is a personality like physician or administrator or any kind of specialist or clinician who is involved in COVID, and you think that a person would be a good speaker, or we can learn from him or her, or and also we can learn more about what's going on in Pakistan, please suggest his or her name to us with contact information. If they agree, then we will approach them and will invite them. We want more participation from Pakistan. This program, although we're learning, all of us are learning here, but is focused and geared towards Pakistan. So we need to really know where Pakistan is at this point, and how we can do more other than just sharing knowledge. So that's why that is my request. Talk to your colleagues and others and just suggest a name. Even if you don't know that speaker, suggest his or her name, and we'll try to reach out to them. Thank you very much for attending all these. Please keep coming. Thank you. Assalamu alaikum.
Thank you, everybody. Assalamu alaikum.
Thank you, everyone. Khuda Hafiz.
Khuda Hafiz.